So this is the power of collaboration, and it's talking about the Da Vinci Project. And if you're not in that session, you just must like the name of the room. I like the name of the room, although I can't say it. Who can? All right. Apparently it's the battle cry, right? So I'm Linda Michaelsen. I'm the Director of Healthcare Interoperability Standards for, that little company you heard about at the last presentation. Thanks, Reen. We're only sending 25 people here. I'm certified in FHIR, CDA, and V2 standards, and I'm a certified educator. I'm a member of the Technical Steering Committee and co-chair CDA Management, and finally I've been the Da Vinci Community Champion for 2 times. And I value my experience with working with the Da Vinci Group highly. So when you value stuff highly, you get to be an in-kind resource and help with these events. And my partner in crime today is my friend Jeff.
So hi, I'm Jeff Brown. I'm with Lantana Consulting Group. I'm Healthcare Standards Advisor. I'm also a member of Da Vinci's Burden Reduction Core Leadership, and I'm the primary author of the Documentation Templates and Rules Implementation Guide. Also certified in FHIR, CDA, and V3 RIM standards. Also a certified educator, and a member of the Technical Steering Committee. It's apparent that Linda and I have a lot of things in common here.
We look just alike, right? We're twins.
Yes. So co-chair of the Financial Management and Implementable Technology Specifications Work Group. And I have over 30 years of experience as a software engineer and data architect, mostly in the healthcare space. So back to you.
I wanted to point out this statement because we have always worked with it in the Da Vinci world. It's HL7's antitrust statement. And I think there's a lot of comments oftentimes and thinking like somehow our Da Vinci is a secret society, and we're not. We'll show you on the next slide our participants, but we really live by the promote fairness in competition. You'll see this slide in any Da Vinci presentation you go to. It is always our first slide because we remind people we're not trying to, corner the market or do any of those evil things. We're trying to make interoperability work from a value-based care perspective, which infers on the next slide some of our participants. Who participates in value-based care? It's the providers, obviously, and we've heard this year, even from President Biden, the initiative to push value-based care further into our work to help, treat patients better, keep them healthier instead of just spend more and more money, as you heard in the last session. The EHRs, and I would argue that we have the most commonly known names in EHRs that participate. And we also have the payers, because they are the ones that I will point out. Linnell James, at 2016, the first HL7 FHIR Connect-a-thon I went to, had a group of payers sitting in the back of the room and talking about the fact that right now they only were getting administrative data, and they needed the clinical data to help their patients and to get them into the right programs and treatment. And from that came Da Vinci. And then, of course, I'm a member of one of the vendors. I believe I'm the first vendor that was there, and I think it was because Linnell thought I was really United Healthcare. But we worked that out over time. So this group is really formed to collaborate. And Jeff, for some reason, I can't move the screen. Okay. Maybe you can. And to make sure that we're building a basis for success. So you'll see in a few slides later, we have a list of all of the work that we've done so far. But we want to make the mostly real-time exchange of data in our implementation guides. We're building the basis for this, and we're making sure that it works in a consensus-building way. We do not want it to be something that a certain group puts together. It doesn't matter what payers say if it can't be implemented. It doesn't matter what providers say if the payers can't implement it. So you have to build consensus. We're also starting to demonstrate the value from our early adopters. There'll be some links later on in the slide deck, but you can see how one of the implementers of the CRD, Coverage Requirement Discovery Work Group, said that they found in their practice 60% of the people requesting prior auths didn't need them. So it's savings like that that will really impact the industry as we move forward. And they continue to reduce the cost to the membership, and you can see on the other slide why that is, part of why that is anyway. If you go back, sorry, we have a lot of in-kind resources. We're not just having contractors that do the work. We have a lot of these projects that have been brought to us by EHRs or payers for needs that they have. And they are willing to sponsor it in some way, meaning they're investing people to lead the group or people to project management the group to keep it going. And that's the way that we can reduce the cost for the membership. And we stand ready to respond to any of the rules that come out. As you know, most of the rules come out as proposed, and we look at those with great scrutiny and try to figure out what we need and do we have it in an implementation guide. You'll also know that when that final rule comes out, things change. So we know that we have to continue to support those implementation guides as the rule comes out and make the changes that are required by that regulation. And if you go to the next slide, Jeff, this year we're taking on some new use cases. The first one is related to postable remittance. This is kind of a marriage of X12 and FHIR, one of the first few. There's been a few others. But there was a group that was strongly felt that they were missing 835 remittance advices. They were going to one organization, needed to go to two, they'd get lost. So this supports the transport of an 835 using FHIR. And they're just starting the work on this, and everyone in here is welcome to join this group as well as all of the other Da Vinci groups. You do not need to be a member to participate. Our calls are public and they're on the HL7 site. We're also working on the updates to our final regulations, and Jeff's going to talk a little bit more about that. One of the things that came out, though, is that the ONC named a new version of US CDI v3, which is supported by FHIR 610, or US Core, sorry, FHIR 610. So we had to bring that into our IGs, and Jeff's going to talk a little bit about how we did that. The biggest thing, and you heard it in the first session today, we have to implement. And we have some projects that are working on that I'll show you in a new slide. Standards are awesome. We're trying to get the word out about them, but they only make a difference when they're implemented. So our strong focus this year is getting them across that line and start people using them in more volume. And to that end, we also work with the FHIR at Scale Task Force, which has a lot of roles in that functionality. So on the next slide, Jeff, you're going to tell us about what we're doing.
Okay, so as was mentioned with ONC's ruling for the basically the use of US CDI, the fact that we are looking at in 2026 the need for US Core 6.1 to be within the implementation guides and used, and we're based in most of these Da Vinci guides on US Core 3.1.1. Okay, we're faced with a little bit of an issue. So number one, how many individuals or companies, organizations are actually implementing? If they are implementing, to what degree? How many resources or artifacts that are being used are actually leveraging US Core? But we'll get to that on the next slide. But the main goal that HL7 and Da Vinci undertook was, how do we limit that possibility? Okay, because number one, as it says up here in the first bullet point, every additional version of US Core that's supported adds complexity and cost, because we're developing. We're developing to handle two different sets of guidance and rules that sometimes are not exactly compatible. Sometimes there's advancements in the next one, so how do you accommodate for both? Supporting multiple versions adds a lot of cost for implementers, because number one, the complexity of the guide builds out. You have a lot more possibilities of development that have to take place, and it just becomes more and more complex. So the more we add to it in terms of multiple versions of US Core, the more that we actually undertake a lot more cost on every single facet that we encounter. Extended support for old versions extend the period of time that we're actually having to support pieces that are outdated. So the key here is that we want to eliminate the possibility of that if possible. So what's been undertaken is nicely depicted in this. I give credit to Lloyd McKenzie, who did most of the legwork on this, to give us this little flow chart that we're looking at right here. So the first piece that we actually have to consider when we're looking at US Core transition is, number one, is there even an alignment with US Core necessary? Some IGs don't have artifacts profiles that are actually dependent upon US Core profiles. So if there's not any, then we just use the Da Vinci specific profiles. Simple enough. But if there are, then now we have to consider, especially if we're doing like US Core 3.1.1 versus 6.1, can we actually meet both of those requirements in a single set of profiles? Sometimes we can, sometimes we can't. But the key here is that, yes, if we can, then we're good to go, because we've got one profile. You're good to go with any set of profiling instances that you want to go with, because they cover both of them, but occasionally, as we see, that's not going to happen. So we have to look at what's the minimal production implementations of the old US Core. So how deeply has this already become entrenched? So if we're looking at minimal, then what you do is you just support the new one, because nobody's really dependent upon the old one yet. We're good to go. If not, then the new Da Vinci functionality would need to support old as well. And if it does, then you support both versions. The key here is, how do we actually go through the process of getting this into the guides as soon as possible? What we're looking at is that most of the Da Vinci guides have already been done. As I mentioned earlier, I'm responsible for the burden reduction guides. I'm part of the core leadership, so I'm one of the IG authors there. So we've already done all the burden reduction IGs, and most of the other Da Vinci guides, I think, are already undertaken as well. So I think we're in a good shape there. Now the question comes up, do we have to reballot? So if we have to reballot, then we got a problem, because it's a lot of legwork, a lot of administrative work that goes into place. So it happens sometimes, but what we're looking at is that for most of these, an SDU updates all, so it doesn't have to go back to ballot. So if there's any significant or new functionality that's raised, we have to actually go back to ballot. So that actually is just a small pain in the side, and I'll pass this on over to
Ian, we only have a few minutes left. We're going to cover some of...
May I make a suggestion? Since we started late, you can either choose to use the 5 minutes Q&A, or you can finish your slides, and then there's lunch, and I think you'll have a table
Yes,
where you
yes.
can do Q&A.
We also have a session this afternoon at 4 o'clock, and we can show some more of this work at that point. So let me ask you, would you rather take questions now? Anybody have any questions? Yes, please.
One of the early slides mentioned that there was quality measure use cases that were
Yes.
applied. And I was talking with a couple other consultants yesterday, and
Back one
I
more.
think there's an acronym
Actually,
CPO having to do with payment operations, that it's only this connection, point-to-point connection is really,
I think we're...
without patient consent, it's only really feasible if it's use cases that fall into payment and operations, of which quality measures do not.
Can you repeat the question for the
Sure.
recording?
And I think probably what you're referring to is TEFCA.
No, Regents, Blue Shield, Blue Cross, there was a slide in there.
Oh, yeah, yeah, in the beginning. Yes, they actually,
What's the question?
the question is, do you, can you use, I guess, FHIR for quality?
Well, without patient consent, you're going to be able to do bidirectional exchange for, say, closing or gaps in care, things that are typically associated with quality measurement. If that doesn't fall under payment and operations, well, then you have a certain level of constraints in how you can use those point-to-point connections. I was curious if that's
Well,
been explored at all.
Oh, yeah, it falls under HIPAA. There's a HIPAA, and there's, I believe, 6 paragraphs in HIPAA. And those 6 paragraphs cover the use of the quality data. And it's done today, it's just done in different formats. So the exchange happens today in like many formats, either in the form of getting a CDA document or getting a spreadsheet or all that. So it is covered under HIPAA to allow for those interactions. And again, I will always say I'm not an attorney, but it's happening today. It's just a way of changing the format of how you exchange it. And then the other part of it is also has to do with, will the auditors accept the data in that format? And they did find in that use case you're talking about with Providence that they would in that particular scenario. So, and I think as CMS moves forward, we'll see more work in that general area around formats. But I thought perhaps there is some discussion under TEFCA about what parts of the purpose of use would allow for the exchange of data for quality measures or risk adjustment. And that came out as an SOP, but in draft, and now they're going to publish, last I heard in June, there are different purpose of use statements around it. Other questions? So we're going to focus this afternoon a little more on our work, but we have built for the 3 rules. Jeff talked about the ONC rule, and then we also will talk a little bit this afternoon around the CMS 0057 and the implementation guides that support it. There are slides on it in the deck, and we talk about the guides. The one point I'll make is that these are highly recommended IGs that came out in 0057. And so we need to, they are not required. Why we know why they're not required. The rule came out, and there were some changes that we knew would need to be made in those IGs, alignment with the new version of the US Core, et cetera. So that's why they are highly recommended, and you'll hear all of the CMS staff say that. We'll talk a little bit more about those IGs this afternoon.
Yes, and thank you, Linda. One other thing I would like to point out, keep referring back to Da Vinci burden reduction. Everyone knows about prior authorization and how important that is, and such a hot topic these days, and specifically the implementation guides here. So apologize that we're trying to skim through this as quickly as possible because we have limited time. But if you're interested to know more about burden reduction, the 3 implementation guides, maybe a 4th, that actually feed into this whole process of prior authorization, then I would recommend you join me on Thursday morning, because I will have a 45-minute tutorial on Da Vinci burden reduction, and we will be digging into the depths and the weeds of burden reduction, the implementation guides, and various pieces of these regulations that you're seeing.
And since we're over, we'll say please join us at lunch if you have any questions. Like Rin says, we have a table.
Yep.
Thank you, everyone.